Good day. Hello, I am Patricia Dalby. I am an associate professor of anesthesiology at the University of Pittsburgh School of Medicine, and I'm going to be presenting the second part of the obstetrical anesthesia course review. We have a lot of material to cover, and the basic format is going to be such. We're going to look at the pathophysiology of complicated pregnancies, including problems during pregnancy and delivery, problems of term and delivery, and the resuscitation of the newborn. This follows the basic content outline suggested by the American Board of Anesthesiology. One of the first things we're going to look at is problems during pregnancy and delivery, and these include antenatal problems, of which all of these are listed. And then later on, we're going to take a look at peripartum maternal medical conditions, the most common coexisting diseases in pregnancy being hypertension and diabetes. But coexisting problems are increasing due to increasing maternal age at pregnancy and better pediatric care of diseases so that the offspring live to reproduce. We are going to cover all these conditions, but briefly: autoimmune disorders, endocrine disorders, heart disease, hematological diseases, hypertensive disorders, neurological diseases, respiratory disorders, renal disorders, and a little bit about human immunodeficiency virus infection. Briefly, in one slide, we're going to touch on anesthesia for the salvage of pregnancy. Anesthesia for cervical incontinence is generally performed if the woman has had recurrent pregnancy losses. The most common cerclage procedures are performed transvaginally, but occasionally there will be a laparoscopic approach for a woman who has a very short cervix that will require a general anesthetic. The majority, though, of cerclage procedures are performed with regional anesthesia as an outpatient procedure and require a neuraxial T8 to T10 level with a spinal or an epidural. But there are certain things that you want to avoid with both general anesthesia and regional anesthesia in these patients. And that one of those is coughing and nausea postoperatively. Some of the obstetricians will advocate use of tocolytics and antibiotics, and these women will need to be monitored postoperatively for contractions and the fetal heart rate if the fetus is in the viable age range. Moving on to anesthesia for spontaneous abortion or miscarriage. Miscarriages can be inevitable, incomplete, and or missed. All of these types of miscarriage eventually require a dilatation, curettage, and evacuation procedure. The choice of anesthetic technique may be individualized for the patient depending on the hydration status and the recent ingestion of food. Also, many centers utilize medication of the misoprostol type that can be used for uterine evacuation as well as expectant management if the patient is not actively bleeding or infected with a miscarriage. At our institution, we commonly use intravenous sedation paired with a paracervical block by the surgeon as our anesthetic technique for D, E, and C in miscarriage. In the United States and Canada, women with bleeding during pregnancy who are RhD negative and unsensitized receive RhoGAM. In other countries, guidelines vary, and the dose may vary depending on the age of the pregnancy, how many weeks the pregnancy is. Going on to the issue of ectopic pregnancy and anesthesia. There are many types of ectopic pregnancy, and ectopic pregnancy includes any pregnancy outside of the uterus. And it can occur with concurrent uterine pregnancies. Most ectopics are fallopian in location, but they can be intra-abdominal, ovarian, cervical, or even intramural in the uterine wall. Ectopic pregnancy is usually diagnosed early now with ultrasound. And this allows for the choice of expected medical or surgical treatments. Approximately 1/3 of women with ectopic pregnancies are candidates for methotrexate treatments. And optimal candidates for methotrexate include women who are hemodynamically stable, able to comply with post-treatment follow-up, and have a HCG that is less than 5,000 milliunits per ml, and have a smaller ectopic mass. But surgery is required when emergency treatment is necessary. There is another planned surgical procedure, or there is a relative or absolute contraindication to methotrexate therapy. And a ruptured ectopic can be a life-threatening situation for the mother. Surgery indications include if the mother is hemodynamically stable because of an ectopic rupture, if she has a desire for concurrent sterilization, or has a contraindication to methotrexate therapy such as peptic ulcer disease, immunodeficiency, or hypersensitivity issues, or she's failed methotrexate treatment. And the usual surgical approach is laparoscopic unless there is intra-abdominal hemorrhage, which precludes visualization of the ectopic laparoscopically and requires a laparotomy. Briefly, we're going to touch on placental trophoblastic disease. There are two types of molar pregnancies. There's the partial datiform mole, which is more focal and often contains fetal material and less associated with systemic reaction. Thyroid storm-like symptoms may occur with these pregnancies or with the advent of their evacuation, however, so attempts should be made to render these women clinically euthyroid prior to their evacuation, and requires preoperative assessment of the mother. However, 90% of molar pregnancies are complete molar pregnancies and more likely to have malignant potential hydropic villi or marked elevations of beta HCG. They also are more likely to have excessive uterine growth, hyperemesis gravidarum, hyperthyroidism or hypertension, more likely to embolize or cause acute cardiopulmonary distress. Pregnancy and hypertensive disease actually occurs in a large number of women and is the most common medical problem during pregnancy. It also encompasses a gamut of disorders. Hypertension occurs in up to 22% of pregnancies, and it contributes to up to 18% of maternal deaths. The definition of chronic hypertension is that diagnosed prior to pregnancy and is considered mild if the systolic blood pressure is less than 140 and diastolic blood pressure is less than 90. but severe if systolic blood pressure is greater than 180 with a diastolic greater than 110. Gestational hypertension is hypertension that occurs without proteinuria after 20 weeks of pregnancy, and preeclampsia is defined as hypertension and proteinuria after 20 weeks with the same definitions of mild and severe by blood pressure criteria. Severe preeclampsia also encompasses hypertensive disorders that have cardiac manifestations, thrombocytopenia, right upper quadrant pain, or fetal growth restriction. Eclampsia is preeclampsia with new onset seizures, and chronic hypertension with superimposed preeclampsia is that of chronic hypertension with new onset proteinuria, abnormal LFT, liver function tests, or thrombocytopenia. There is also the posterior reversible encephalopathy syndrome, and that is the radiological clinical syndrome that can occur during pregnancy, most often in association with eclampsia. And it represents an acute increase in blood pressure accompanied by headache, seizure, visual defects, or an altered sensorium. The cure of preeclampsia is delivery of the fetus in the placenta. Blood pressure can be controlled with magnesium and may be aided by the utilization of epidural anesthesia, but in addition, other antihypertensive agents are commonly used, such as hydralazine, a vasodilator, labetalol, methadopal, dopa, an alpha-adrenergic agonist, and for intractable cases, nitroglycerin, sodium nitroprusside, or the calcium channel blockers such as nicardipine. Intravascular volume may actually be decreased in preeclamptics, but maintenance has to be done with judicious fluid boluses to avoid volume resuscitation. Preeclamptic women often receive magnesium sulfate for central nervous system protection from seizures, and they need to be monitored for dynamic changes in their liver function tests, renal function, platelets, and hemoglobin, and have a blood type and screen available since they are more likely to have bleeding problems. Preeclamptic women are at higher risk for cesarean delivery because of problems with uteroplacental insufficiency. And this may be an urgent operation. So careful airway evaluation must be done because these women are more likely to have generalized edema and membrane friability. Many centers consider preeclamptic women in labor candidates for early epidural catheter placement. If one does provide a general anesthetic, one does not want to give a defisculating dose of non-depolarizing muscle relaxant because these women are very sensitive to muscle relaxants secondary to receiving magnesium. And the intubation itself may require pretreatment for hypertensive responses with agents such as labetalol. Spinal anesthesia or combined spinal epidural techniques have now been found to be very safe even in urgent cases for women who are preeclamptic who require a cesarean section. And the hypertensive effect of methylorgonavine, Methergin, as a unitonic agent precludes its use in preeclamptics except for severe bleeding disorders. Often the preeclamptics receive magnesium for 24 to 48 hours after the operation for seizure prophylaxis. The HELP syndrome is a variant of preeclamptics. HELP stands for hemolysis, elevated liver enzymes, and low platelets. We have previously stated what other things are involved with severe preeclamptic definition. And this syndrome is different from the normal hematological involvement of preeclamptic women with lowered platelet counts. Platelet counts in HELP syndrome can decline to extremely low levels, below 50,000 cells per millimeter cubed, and the change in liver function tests can make them vulnerable to bleeding problems and thus more likely to develop epidural hematomas if a regional technique is utilized. Thus, the recommendation in severe preeclamptic to monitor serial platelets every 6 hours and have a recent platelet count prior to placing or removing an epidural catheter. The decision in women with HELP syndrome to perform neuroaxial anesthesia is based on the rapidity of the platelet decline, the absolute platelet count, and, if available, adjunctive test results such as thromboelastography. When preeclampsia develops seizures, eclampsia evolves. To treat eclamptic emergencies, one wants to stop the seizure, and the seizures are usually self-limiting. Treatment is with magnesium bolus, or if IV access is not available, intramuscular magnesium. Very rarely is the need for propofol or benzodiazepines, which may cloud the postictal evaluation. One does need to maintain adequate oxygenation and ventilation during eclamptic seizures and give the mother 100% oxygen and assisted ventilation. Intubation is considered only if seizures are prolonged or there is an aspiration risk. And other things that should be maintained are things such as left lateral uterine displacement, assessment and control of the blood pressure, and elimination of other causes of the seizure such as a low blood sugar or previous seizure disorder, and consultation with the obstetrician about their perception of the urgency of delivery. Going back to magnesium sulfate, maternal side effects may include flushing and rarely muscle weakness. Clinically, as these mothers are monitored for loss of deep-tended reflex and decrease in urine output, occasionally there will be an inadvertent bolus of magnesium in these women. And treatment of maternal toxicity is reversal with calcium, either 1 gram of calcium chloride or calcium gluconate, repeated as necessary until the mother has regained consciousness and is reflexive. Going on to talk briefly about all the pregnancy-associated emergencies. There are antepartum emergencies, which are listed and have fetal or neonatal effects, intrapartum emergencies that are listed and can cause fetal asphyxia or fetal birth injury, and postpartum emergencies that are listed, which can affect the mother most commonly. However, clinically, urgent problems of delivery often translate into emergency cesarean deliveries. But emergency cesarean deliveries have been thought to be able to be classified into those that are stable, those that are urgent, and those that are stat. For a stable emergency cesarean section, often an epidural can be dosed or a spinal can be instituted. And those include such things as abnormal fetal position and chronic uteroplacental insufficiency. Urgent need for cesarean delivery includes such things such as cord prolapse, variable decelerations with good recovery, dystocia, a failed trial of forceps, and laboring woman with a previous classical scar. These also can often be anesthetized with extension of a pre-existing epidural or spinal. However, there are several really urgent stat indications for cesarean delivery and these include things such as massive maternal hemorrhage, a ruptured uterus, cord prolapsed with fetal bradycardia or agonal fetal distress, and these most often will require a general anesthetic if the mother is a good candidate. However, with the institution of general anesthesia, the problems associated with general anesthesia can happen, such as difficult or failed intubation and aspiration. General anesthesia-associated problems are minimized by good interdisciplinary communication, and aspiration precautions should be taken in these women who need to have this done even in the in the stat C-sections, such as non-particulate acids. A rapid sequence induction technique should be utilized, and these women should be intubated. To avoid difficult intubation, optimal maternal positioning with a ramp and back up difficult airway techniques should be utilized. With general anesthesia, one must remember that volatile agents do decrease uterine tone and increase bleeding, so should minimize their use after delivery and provide the mother with analgesia by narcotics. Post-operative pain problems also become evident due to the lack of neuraxial opiates in women who undergo general anesthesia solely for cesarean section anesthesia, and the thought may be given to utilizing multimodal therapy with some of the NSAIDs and other agents. The cord prolapse is multifactorial, but it is a true maternal and fetal emergency. And there are many risk factors for cord prolapse unrelated to obstetrical maneuvers, but then there's also cord prolapse tendencies that are associated with obstetrical maneuvers, and these may occur immediately after iatrogenic rupture of membranes, the application of an internal scalp electrode, insertion of an IUPC or manual rotation of the fetal head, or during external cephalic version techniques or application of forceps. Maternal hemorrhage is a leading cause of maternal death, but there are certain intrapartum situations that are associated with maternal hemorrhage, and these include the presence of a placenta previa, presence of an abruption, vasoprevia, or the presence of some sort of accreta during the pregnancy. The abruptio placenta is the separation of an abnormally implanted placenta after 20 weeks gestation before delivery. It is fairly low incidence, but maternal mortality is still about 2 to 3%. It can be mild, moderate, or severe, and does not always elicit immediate delivery. But perinatal mortality is also fairly high. and can lead to coagulopathy and or fetal distress. Predisposing factors for abruptio of placenta include hypertensive disorders, high parity, uterine abnormalities, previous abruption, cocaine abuse, and trauma, and it's generally a painful experience for the mother. This is unlike placenta previa, which is usually not a painful experience for the mother, and has a fairly high incidence also. It can be a recurrent problem for women who've had previous placenta previas and can be classified as complete, covering the entire cervical os, partial, covering part of the os, or low-lying, and may be associated with placental uterine wall invasion. Another interpartum event associated with hemorrhage is uterine rupture. And this may occur in women who've had a previous cesarean section with scarring or a previous uterine myomectomy for fibroids. It's associated with rapid spontaneous labor and also prolonged labors with or without cephalic pelvic disproportion. It often occurs in weak, stretched uterine muscle that occurs with multiple gestations, polyhydramnios, or the mother has had many, many babies. It can occur from trauma from intrauterine manipulation. The signs and symptoms of a uterine rupture often include such things as vaginal bleeding, severe uterine pain that occurs abruptly, even despite the existence of an epidural, shoulder pain, or fetal distress with disappearance of fetal heart tones, maternal hypotension, and shock. If one is put into the situation where one has an urgent delivery and requires a general anesthetic, here is a general approach. One wants to ensure IV access and ask about antibiotics if given the time and opportunity, give the mother a non-particulate antacid administration so that she is less likely to have detrimental effects of aspiration, pre-oxygenate her, as well as apply the standard ASA monitors. Tell the surgeons to go ahead and prep and drape, though the drape may be kept low so as to facilitate communication. A rapid sequence induction and intubation technique is then utilized, and intubation and confirmation of placement of the endotracheal tube with breath auscultation and capnography is performed, and as soon as that is performed, you can inform the surgeons that they can start the operation. Generally, one will deliver 100% oxygen with a small amount of volatile agent prior to delivery, and post-delivery give nitrous oxide with a very small amount of volatile agent so as not to contribute to uterine contractile difficulties, and administer oxytocin. One wants to monitor the uterine tone and bleeding and extubate the patient awake if at all possible. Associated with general anesthesia, one will occasionally encounter a difficult airway. And recent failed tracheal intubation inquiries in the United Kingdom associated their cases primarily with three factors: mothers that were obese, who were older, and had a greater recording of Mallampati score, such as Mallampati 3 or 4. This will necessitate that you always have difficult airway equipment available if having to provide general anesthesia to a mother. The usual predictors of difficult airway should be ascertained, if at all possible, preoperatively and accounted for, and are not very much different than the usual indications, other than that fact that mothers have swollen membranes and can have very large pendulous breasts. The ACOG guidelines actually do address difficult airway concerns, in that they say failed intubation and pulmonary aspiration of gastric contents continue to be leading causes of maternal mortality and morbidity from anesthesia, and the obstetric care team should be alert to the presence of the risk factors that place the parturient at increased risk for complications from emergency general or regional anesthesia. When risk factors are identified, the obstetrician should obtain antepartum consultation with the anesthesia care providers and develop strategies to minimize the need for emergency induction of general anesthesia in women for whom this could be very hazardous. That translates generally into a good working epidural, and is the policy of most high-risk centers. Another problem that contributes to bleeding and can be an urgent problem in delivery is the development of severe infection. And infections can occur, fever can occur from multivariable sources during pregnancy, but the bad actors are sepsis and pneumonia. However, there exist algorithms that differentiate ways to look at fever during pregnancy and delivery, and take into effect the fact that epidural anesthesia can also contribute to fever. Infected women are more likely to have postpartum hemorrhage, and postpartum hemorrhage is a major maternal morbidity factor. Postpartum hemorrhage can also occur with retained products, uterine atony, cervical and vaginal lacerations, and the treatment priorities of postpartum hemorrhage include 4 factors. 1, uterine tone. 2, ascertaining whether or not there was retained placenta or products. 2, 3, whether there has happened to have genital tract trauma. And 4, whether there's a coagulation abnormality going on. There are multiple maternal hemorrhage algorithms. This is just one that was proposed by Walfish and Wody in the British Journal of Anesthesia in 2009. But they all involve monitoring the mother more closely, controlling the airway early, increasing the intensity of monitoring with such things such as intra-arterial catheters, placing large bore intravenous access, obtaining blood and blood products. Somewhere down the line of uterine atony treatment is the utilization of the medical treatments of atony, such as oxytocin, methylgurnamide, the prostaglandins, and misoprostol, and then eventually surgical interventions. Oxytocin is the first-line uterotonic. It may be overutilized. It does have side effects of SIADH and water intoxication and electrolyte disorders. The uterus may become refractory to oxytocin. Secondary medical therapy includes methylgurnamide And it also has its side effects and is relatively contraindicated with uncontrolled hypertension. The prostaglandin F2 alpha is also a second-line uterotonic that is generally administered intramuscularly but can be intramyometrally. It can also have side effects that is the most concerning being those in asthmatics, in which it could cause bronchoconstriction. And then there's the use of misoprostol, which can be given orally, but in an emergency is generally given rectally, and is contraindicated if there's active gastric ulcer disease, and has increasing evidence of uterotonic efficacy moving up the treatment hierarchy. Other things that have been utilized in severe cases of coagulopathy in the postpartum period have included recombinant factors 7A, but more prevalently tranexamic acid, which is a fibrinolysis inhibitor best used prophylactically, but has been used in acute bleeding. There is some concern about the promotion of thromboembolism with its use. However, there's a worldwide antifibrinolytic trial going on, and the dosage is 1 gram IV, and is becoming very common in most large centers that take care of high-risk mothers. And though the ultimate cure for uterine atony and bleeding is hysterectomy, other strategies include cell salvage, autologous donation, and rapid infusion devices for blood. The retained placenta is a very common problem that will cause postpartum bleeding. It may require an urgent postpartum D&C, and occasionally will actually require uterine relaxation for removal of the products, because the cervix may have contracted in the lower segment and trap the products in the upper segment of the uterus. If uterine muscle relaxation is required for retained products, or even such things as breech extraction, it can be provided with general anesthesia, but an attempt of using a medical therapy such as nitroglycerin or beta-2 agonists may avoid airway problems. So commonly now, centers are utilizing nitroglycerin for uterine relaxation. It causes a transient but profound uterine relaxation, and can be provided with intravenous doses of 50 to 100 mics of nitroglycerin, or sprays, nasal sprays, 2 doses. It may require to be redosed, since its half-life is so very short, and often requires very careful double dilution and measurement of the 50 milligram of vials that are available in the USA now. We're now going to move on into peripartum maternal medical conditions, including autoimmune disorders and the like. Autoimmune disorders in pregnancy include lupus, which also is associated with the antiphospholipid syndrome. SLE is the most common encountered autoimmune disease in pregnancy, which may, and pregnancy itself may aggravate the disease. It's a chronic inflammatory disease characterized by autoantibodies against nuclear structures, especially DNA, and embolic phenomena are common in these patients. 50% of these patients have cardiac involvement. Other organ systems involved may include the neurologic, pulmonary, renal, and hematological systems. Patients may be thrombocytopenic, leukopenic, and anemic. The antiphospholipid antibody syndrome has a strong association with SLA with tendency to form vascular thrombi, so patients may be chronically anticoagulated. Other medications that these pregnant women may be on include the NSAIDs, steroids, methotrexate, and immunosuppressant medications. Going on to the endocrine disorders, diabetes affects up to 12% of pregnancies, is one of the more common maternal comorbidities, and is more common in pregnant, older, and obese women. There's a physiological insulin resistance of pregnancy that is created by the placental hormones that serves to create a glucose gradient from mother to fetus and macrosomic fetuses. Maternal hyperglycemia leads to fetal hyperglycemia, resulting in fetal hyperinsulinemia, and may result in fetal macrosomia, but then also fetal hypoglycemia after the baby is born. A common diagnosis of the diabetes in pregnancy is the white system, which is based on the duration of diabetes and the amount of end organ involvement. Women who have never been diabetic before pregnancy are called gestational diabetics and are either diet controlled or on some sort of therapy. Diabetic babies tend to be larger and therefore associated with the higher risk of shoulder dystocia and birth trauma. Also, there's an increased risk of intrauterine fetal demise, polyhydramnios, operative delivery, and neonatal metabolic complications such as hyperbilirubinemia in babies born from diabetic mothers. Another not so uncommon endocrine disorder during pregnancy is our thyroid problems. There are, in normal pregnancy, a decrease in TSH and an increase in thyroid binding hormone, but free T3 and T4 levels remain the same. Hashimoto's thyroiditis is the most common cause of hypothyroidism in countries that don't have iodine supplementation, and commonly occurs in the postpartum period. Pregnant women with hypothyroidism are at risk for stillbirths, IUGR, intrauterine growth restriction, and a host of other problems, while their infants have increased neurodevelopmental delays issues. Graves' disease is the most common form of hyperthyroidism in pregnancy, which is diagnosed by a low TSH and elevated thyroid hormones, and hyperthyroid women may require thiamide treatment and beta blockade for tachycardia. Graves' disease is associated with thyroid antibodies that may cross the placenta and render the fetus hyperthyroid, and thyroid storm may occur in these women and be associated with labor, infection, cesarean delivery, and preeclampsia. Of the adrenal disorders in pregnancy, the most life-threatening is pheochromocytoma, which may be confused with severe preeclampsia due to hypertension and occasional associated proteinuria. These women are likely to have labile severe high blood pressures. However, they may require surgical treatment for the tumor if it occurs early in the pregnancy. Diagnosis is based on urine or plasma metanephrines, is treated medically with alpha blockade and subsequent blockade, and if allowed to persist during the pregnancy, cesarean section is the preferred delivery mode in this condition so as to cause less adrenal compression. And if the mother has adrenal insufficiency, they will require continued supplementation and stress doses of medications around the time of delivery. Touching on heart disease during pregnancy, most pregnant mothers with all types of heart disease are now continuing their pregnancies to term and being delivered. More women have coronary artery disease because there is a tendency towards advanced maternal age, and more women with better medical care survive to reproductive age with congenital heart disease. Mothers with heart disease should be classified by their functional capacity, such as the New York Heart Association classifications, with better fetal outcomes correlating with better maternal function classification. Labor itself actually increases cardiac output demands by almost 50%, but the highest demand is in the postpartum period with the autotransfusion that occurs as the uterus contracts, and this is often a time of maternal decompensation if it's going to occur. Before labor, cardiac consultation should be obtained with the maternal cardiologists and the obstetrician. Interdisciplinary involvement and guidelines for antimicrobial prophylaxis should also be obtained. Cardiomyopathy may occur from the usual multiple etiologies associated with it. It is defined as maternal ejection fraction less than 45%. Peripartum cardiomyopathy is defined as the new onset of cardiomyopathy during pregnancy or up to 5 months after delivery. The prognosis is generally good for women with peripartum cardiomyopathy, with the improvement of most women by 6 months postpartum, but it does have a tendency to reoccur with subsequent pregnancy. It also may occur cardiomyopathy may occur more often in mothers with advanced age or those with multiple gestations, or unfortunately those of African descent. Treatment of cardiomyopathy can be the usual preload and afterload reduction, and occasionally inotropic support such as digoxin. And the use of ACE inhibitors, however, is contraindicated in pregnancy because they are known teratogens. Congenital heart disease is becoming more prevalent in the care of pregnant women as they survive to older ages. And Eisenmenger syndrome is associated with a very high maternal mortality, up to 50%, and especially in that immediately postpartum period. It occurs in women with poorly treated left to right shunts, such as the VSD, SD, PDAs. And care of these patients must be multidisciplinary and occasionally requires resources such as inhaled nitric oxide and prostaglandin infusions. Left to right shunting cardiac lesions, women with the larger left to right shunts may develop pulmonary hypertension and tolerate pregnancy very poorly. They can have paradoxical embolisms that can cause strokes. Right to left shunting cardiac lesions such as tetralogy of Fallot generally do well if corrected, but may have problems if uncorrected, such as arrhythmias, heart failure, worsening cyanosis, or emboli via residual VSD. And most of the congenital heart disease lesions do require antimicrobial prophylaxis during delivery to prevent bacterial endocarditis. Women with valvular heart diseases tolerate the regurgitant heart lesions better than the stenotic ones, because, especially with the increase in plasma volume in pregnancy. Women with stenotic cardiac lesions do not tolerate a sudden drop in systemic vascular resistance due to the rapid onset of sympathectomy or hemorrhage. And in women with fixed stroke volume, such as seen in aortic stenosis, cardiac output is very dependent on heart rate, and arrhythmias or bradycardia can lead to cardiac ischemia and syncopal symptoms. The same problems occur in women with mitral stenosis, but to a lesser degree than those with aortic valvular stenotic lesions. Anesthetic techniques that are optimal maintain preload, such as intrathecal narcotics with the slow onset of epidural-induced sympathectomy, or general anesthesia are generally preferred in women with stenotic valvular disease. And these women may require much more intense cardiac monitors in the transesophageal cardiography, as well as arterial line placement. Pulmonary hypertension can be the result of prolonged cardiac, pulmonary, or embolic disease. Pulmonary hypertension is aggravated by hypoxia and acidosis and pain, and defined in pregnant women as PA pressures greater than, pulmonary artery pressures greater than 25 millimeter of mercury at rest. Pregnant women with severe pulmonary hypertension are at high risk for an operative death spiral and should be continued on medications that they normally take for this disorder in the peripartum period, including intravenous phosphodiesterase type 5 inhibitors such as sildenafil, prostanoids, or inhaled nitric oxide. And regional anesthesia is preferred in these women, but they do not tolerate a rapid drop in their preload and systemic vascular resistance. Touching upon the issue of arrhythmias in women with heart disease. Women with mitral valvular disorders often develop atrial fibrillation, and women with cardiomyopathies may develop bundle branch blocks or tachyarrhythmias. With the onset of atrial fibrillation, there is the loss of the atrial kick, and this can be disastrous if a mother has a fixed cardiac lesion, such as mitral stenosis or aortic stenosis. Supraventricular arrhythmias are fairly common in pregnancy and respond to adenosine and other medical therapy, such as dithiazem and beta blockade. But pregnant women can undergo synchronized electrocardioversion if hemodynamic instability occurs. There's a very high incidentally, of ST wave abnormalities and extra beats found in women undergoing cesarean section with regional anesthesia techniques in the general population. Now moving on to the hematological diseases. These include such things as sickle cell anemia, idiopathic thrombocytopenia, the von Willebrand disease, and then the acquired problems such as disseminated intravascular coagulation, anticoagulate therapy, and problems with blood incompatibilities. So these hematological problems during pregnancy can include pre-existing, acquired, iatrogenic, or treatment problems. Gestational thrombocytopenia is generally milder and self-limited with 5 diagnostic criteria, which include no pre-existing maternal platelet problems, the occurrence late in pregnancy, patient is actually asymptomatic of the thrombocytopenia and normally has platelets above 100,000. No fetal problems with platelets, and generally gestational thrombocytopenia will resolve postpartum. Women with sickle cell anemia have vaso-occlusive disease and so may have more placental pathology with pregnancy loss, be more likely to have preeclampsia, abruptions, or intrauterine growth retardation. These women with sickle cell anemia need to have hydration maintained, be kept warm, and be well oxygenated. And it's not uncommon for mothers to have several sickle cell crises during the course of the pregnancy, which require admission. Idiopathic thrombocytopenia in a pregnant woman can be confused with gestational thrombocytopenia, but is pre-existing or presents earlier in the pregnancy than the other. There is a risk of neonatal hemorrhage, especially if the mother has had splenectomy because of pre-existing disease. And it can be associated with very low platelet counts that may respond to steroids. Mothers with von Willebrand's disease, there are several different types of this disease. Type 1 is the most common, responsive to DDAVP, but often not needed, as milder forms of disease tend to self-correct with pregnancy. The disorder is one of the von Willebrand factor and factor VIII quantity and quality. These women should have hematology consultation early in pregnancy to determine which type of von Willebrand disease the woman has and its responsiveness to DDAVP. And rarely these women can have delayed postpartum hemorrhages. Acquired disease include disseminated intravascular coagulation that may occur most commonly with maternal hemorrhage or as the result of this HELP syndrome or severe preeclampsia. And the treatment of this is supportive as usual with blood product administration and correction of the underlying etiology of the disseminated intravascular coagulation. Problems with blood typing is generally due to clerical error, but in light of need of multiple transfusions. Both red cells and fresh frozen plasma should be ABO compatible. Platelets and cryoprecipitate do not need to be. Going on to hematological disease as a result of therapy. Pregnancy is a known hypercoagulable state, and pregnant women may require anticoagulation because of venous thromboembolism during the pregnancy or because they've had a thromboembolism in the past. Also, they may require anticoagulation for autoimmune diseases such as lupus or inherited clotting disorders such as factor V Leiden, or because they've had a heart valve replacement. Coumadin is generally contraindicated in pregnancy because it's a known teratogen. So patients will usually be treated with heparin of some sort, and prior to delivery, that is usually low molecular weight heparin for the first part of the pregnancy with a transition to subcutaneous unfractionated heparin closer to delivery. Usually for the full therapeutic anticoagulation, the low molecular weight heparin will have to be given twice a day. As guidelines pertaining to the administration of neuraxial anesthesia are safe to follow in these situations of maternal anticoagulation. They require a full 24-hour wait after the BID doses of low molecular weight heparin. Mothers with neurological diseases commonly present to the labor and delivery suite. One of the most common are epileptic mothers who, for the most part, have uncomplicated pregnancies but are at a higher risk of spontaneous abortion, hyperemesis gravidarum, fetal birth defects, and seizures. Any of the antiepileptic medications can cause fetal dysmorphic features, but some are more commonly associated with that. Also, the antiepileptic medications may alter folate metabolism and vitamin K metabolism, and additional supplementation of the mother with these supplements may be needed. Epileptic mothers are at risk for breakthrough seizures due to alterations in the blood concentration of the medications related to maternal physiological alterations, and they may be more likely to have a seizure if they are sleep deprived or receive meperidine. If a mother has a prolonged seizure during labor, it can elicit a fetal bradycardia and thus instigate an emergent C-section. Rarely, mothers of childbearing age may have pre-existing spinal cord lesions. Depending on the level of the injury, there may be respiratory compromise of the mother and altered pain or motor sensation and function. Spinal cord lesions above T7-8 are the most problematic, in that thermoregulation can be altered in these mothers, and autonomic dysreflexia will occur in over half of these mothers. It can be autonomic dysreflexia can be elicited by noxious stimuli below the level of the injury, such as labor or catheterization, and elicit a massive sympathetic discharge above the level of the injury. Neuroaxial anesthesia will block this reflex, but the epidural provides the continuous catheter, and so is the preferred technique, or antihypertensive medications may be needed in these women to treat the autonomic dysreflexia. Also rarely, pregnancy and the immediate postpartum period can be associated with problems with subarachnoid hemorrhage. This is because their pregnancy and postpartum are a time of increased susceptibility for cerebral bleeding, which may be aggravated by pushing in the second stage. And if this occurs, is generally felt by the woman as the worst headache of her life, but may be associated with small warning bleeds. It can be confused with other headache-causing etiologies such as preeclampsia or post-dural puncture headache. If it occurs, it can be from ruptured arteriovenous malformation or aneurysms, which may be able to be embolized radiologically if found early enough. But if bleeding occurs, surgery may be needed, and the usual careful blood pressure control and anti-seizure medications may be needed intraoperatively and postoperatively. Other neurological diseases associated with pregnancy include multiple sclerosis and myasthenia. Multiple sclerosis is very common in women of childbearing age, and pregnancy may improve the symptoms. Triggers for problems in women with MS may include hyperthermia and exhaustion, however. And in providing anesthesia for the mother, usually in the form of an epidural, pre-anesthetic evaluation should detail existing neurological deficits. Also, it must be remembered some of these women may be treated with other agents such as corticosteroids, interferon, or immunosuppressants. And the concern about spinal anesthesia in these women has been largely discredited in the recent years. Myasthenia may have a variable course during pregnancy, and it may be exacerbated by the tocolytic or preeclamptic medications and prolonged pushing. Anticholinesterase inhibitors used for its treatment may cause uterine contractions, and high levels of regional blockade in these women may not be tolerated well. The most common respiratory problem in pregnancy is asthma and has a variable effect. 20% of pregnancies are complicated by worsening symptoms, and these can be treated in the usual way with beta agonists and steroids, and rarely mothers require hospitalization or ventilatory support. Ventilatory support for respiratory failure, though, has been an issue recently in pregnant women who are susceptible to H1N1 influenza and other types of pneumonia secondary to the natural immunosuppression of pregnancy. Also, exacerbation of pulmonary symptoms is secondary to the restricted component of pulmonary disease associated with pregnancy-induced maternal physiology. Many of these women who have required ventilatory support have required high levels of expiratory pressures for adequate oxygenation. And the fetus actually tolerates a mild respiratory alkalosis and a mildly hypoxic environment fairly well. Another commonly described respiratory disorder in pregnancy is that associated with obesity, with pregnancy and obesity both causing a restrictive lung defect. This is the entity of obstructive sleep apnea. It is also more common in mothers who have diabetes and hypertension. Obstructive sleep apnea is often associated with difficult airway management in these women also. If the women are currently being treated with CPAP or BiPAP, these therapies should be continued throughout the pregnancy and into the postoperative period. And the obstructive sleep apnea, an anatomical component, may be exacerbated in labor due to swelling of the airway. And if it is a chronic problem, may be associated with maternal pulmonary hypertension. Pregnant women are susceptible to post-renal obstruction due to the enlarging uterus during pregnancy, and in many with this problem will require repeated urological stents during their pregnancy. Most of the time, spinal or intravenous sedation anesthesia will suffice for these procedures. Normally, the glomerular filtration rate increases in pregnancies with a decrease in the creatinine and the BUN volumes. In the preeclamptic woman or the normal pregnant woman, therefore, a high normal or mildly increased laboratory value of renal indices may indicate a larger amount of renal compromise than it would suggest in a non-pregnant woman. And this may be exacerbated with the intravascular restriction volume in preeclampsia and also intrinsic renal dysfunction that occurs with preeclampsia. Lastly, many mothers have an unknown human immunodeficiency viral infection status. If it is known, vertical transmission to the infant is reduced through antiretroviral therapy and also through the utilization of cesarean delivery for birth. In known women with HIV infection, CD4 count should be monitored during the pregnancy, as well as the viral load. And the women should be continued on their antiviral agents. Regional anesthesia is not contraindicated in women with HIV infection, nor is the administration of epidural blood patches. One disastrous reason for admission of a woman to a critical care unit in pregnancy is if she develops the amniotic fluid embolism, which is also called the anaphylactoid syndrome of pregnancy. This catastrophic condition occurs during pregnancy and labor or shortly after delivery. It has been estimated to be very rare, with 1 to 12 cases per 100,000 deliveries, and it is a diagnosis of exclusion. It presents as hypotension due to cardiogenic shock, hypoxemia, respiratory failure, disseminated intravascular coagulation, coma, and seizures. and the treatment is supportive care, transfusion, vasopressors. The right heart failure is often followed by left heart failure if the patient survives the initial onset of circulatory arrest. More commonly, though, women will be admitted for another type of embolic disorder during pregnancy to a critical care medicine unit, and that is that of thromboembolism. Pulmonary embolism is the leading cause of mortality during pregnancy in the postpartum period and is responsible for 20 to 30% of maternal deaths. It presents with a wide variety of features, from no symptoms to shock or sudden death. Non-specific presentation is magnified during pregnancy due to an overlap of the symptoms with normal physiological changes of pregnancy, but should be suspected in pregnant women with onset of acutely of dyspnea, pleuritic chest pain, and hemoptysis. It requires an accurate diagnostic approach and so that appropriate treatment with anticoagulation can be initiated, and requires full anticoagulation for 3 to 6 months after a DVT or the pulmonary embolism, usually with heparin of some sort. The American Heart Association guidelines in 2010 addressed the rare occurrence for the need of advanced cardiac life support and basic life support in pregnancy. There are pregnancy-related modifications to cardiac resuscitation. And one of these include providing left lateral uterine displacement by manual displacement, and also to an algorithm to search for the possible causes, both CHOPS. B for bleeding, E for embolism, A for anesthetic problems, U for uterine atony, C for cardiac disease, H for hypertension, O for others, P for placental problems, and S for sepsis, these being the most common cause of maternal cardiac arrest. The other than left lateral uterine displacement is preparation for cesarean delivery of the baby within 5 minutes of the arrest if the mother remains in arrest. It is advocated that you get the mother on a hard, flat surface, that you do chest compressions above the center midpoint of the sternum with left lateral uterine displacement. If you have a shockable rhythm, treat it as usual, but try to remove the fetal monitors prior to defibrillation. And the manual displacement of the uterus is advocated by the 2010 guidelines, which actually will undergo revision again this year. The perimortem C-section, the goal is to start within 5 minutes of maternal cardiac arrest. Very good neonatal survival has been documented until 15 minutes of arrest, and neonatal resuscitation may be required, so be prepared with the things such as in the neonatal resuscitation equipment list here, and have a supply of neonatal resuscitation equipment portable for such emergencies. The perimortem cesarean section should be thought of as a resuscitation necessity for the mother, not for the baby, so as to improve maternal cardiac output. You need to have very simple stat C-section supplies available, such as in this list, and do the operation right where the patient has gone into arrest. Do not move to an OR because it takes away valuable time for resuscitation, and it will not be a very bloody operation since there is no circulation in true arrest. We're going to touch a little bit more on intrapartum fetal assessment, including fetal heart rate monitoring, fetal scalp blood gases, and fetal pulse oximetry. We're going to touch a little bit about fetal heart rate monitoring modalities. Actually, non-invasive intermittent Doppler and stethoscope modalities is considered allowable, but the usual setup is with a tocodynamometer and continuous fetal Doppler heart rate assessment, continuous cardiotocography. More invasive intrauterine pressure catheter for pressure monitoring and direct fetal heart rate electrodes is a more invasive way of monitoring the fetus. You can also obtain fetal scalp gases. However, these are not utilized as much as in the past and are very difficult to obtain, have to be processed immediately and represent a capillary sample. In most studies, pH less than 7.2 is worrisome, and pH less than 7.0 ominous. Intrauterine fetal resuscitation can be done, and the patterns that are associated with different causes and treatments can be taught. Modalities of intrauterine resuscitation that an anesthesiologist can do is to maintain uterine blood pressure, improve maternal position, and maintain maternal oxygenation. Uterine relaxation is usually done by the obstetrician, but it includes such things as stopping oxytocin and administering terbutaline. And the mechanism of relieving aortic compression is detailed in this diagram. Reduction of uterine activity and fetal distress by uterine relaxation improves fetal oxygenation, and uterine hypercontractility with oxygen can actually induce fetal heart rate problems. Tocolysis works via this algorithm to to improve fetal oxygenation. Fetal pulse oximetry is primarily a research tool. The oximetry values did not correlate well with pH values. It was dependent on the Lambert-Beer law that determined how light was absorbed, and was interfered with by meconium, fetal scalp swelling, inability to pick up pulsations. And also fetal pulse oximetry did not work well with things such as dark skin pigmentation, hair, low amplitude states, and motion artifacts. Resuscitation of the newborn is a topic that I was asked to talk about. It involves the APGAR score, uterine cord blood gas measurements, techniques and pharmacology of resuscitation, and with a touch on intrauterine surgery. Newborn resuscitation has an emphasis on airway, breathing, and circulation in that order. But the primary responsibility of the anesthesiologist in the labor and delivery suite is to the mother. Usually there are people who will do the neonatal resuscitation for the baby, which involves initially suction of the infant's secretions, which is done by the obstetrician at the delivery of the fetal head, then initial steps involving warming and drying the newborn and stimulation of the newborn. Positive pressure bag ventilation can be done initially, except in the case of meconium where intubation and suctioning takes priority. If the baby goes on to need further pharmacological support, epinephrine administration can be given via the endotracheal tube, umbilical vein, or intravenously. The neonatal circulation system requires transition from a parallel circuit to an in-series circuit, and things that will hamper this transition include fetal hypoxia, hypercarbia, hypothermia, indomethacin administration to the mother, and acidosis. APGAR scoring is a common scoring pattern at birth. It assigns scores at 1, 5, and 10 minutes after birth. It's a measure of the response to an infant's need for and reaction to resuscitation, and it was actually developed initially by Virginia APGAR, who was an anesthesiologist, and it relies on points given for color, respiratory effort, heart rate, reflex irritability, and muscle tone. Occasionally, fetal umbilical cord gases are taken after birth from a cord sample and can be used for medical legal purposes if poor. It requires both an umbilical artery and venous sample, and it relies on 3 basic tenets. Baby is only good as the mother. Venous blood is an indicator of placental function. Arterial blood is an indicator of plumbing and fetal well-being, and is hard to obtain from either artery. And normal umbilical cord values are as in this diagram. Cord gas values indicate integrity of the placental venal circulation and require a heparinized sample of both arterial and venous blood drawn immediately after delivery. Umbilical cord gas measurements, the implications for uteroplacental insufficiency are there if both artery and venous samples show low oxygenation and hypercarbia. Uterine cord compression occurs if umbilical venous samples are relatively normal and arterial samples poor, and there's a wide venous arterial difference. And normal cord gas values are common with fetal depression postpartum due to drugs, sepsis, and acute birth trauma. The last topic that I was asked to talk about were fetal procedures and surgery subgroups. And these are listed from least invasive procedures to more invasive. The least invasive is needle procedures entering the uterus only, such as amniocentesis, chorionic villus sampling that are usually done under local anesthesia only. Then there are needling procedures that actually touch the fetus or umbilical vessels, including percutaneous umbilical blood sampling procedures, shunt procedures, surgical photocoagulation of communicating placental circulations, the TRAP procedure, which is radiofrequency umbilical cord ablation, and these may involve local anesthesia and sedation modalities, but the more complicated will be aided with a regional anesthetic techniques such as an epidural or CSC that will allow for conversion to an anesthetic for an urgent delivery. There are also then in the hierarchy of invasiveness, surgical procedures done directly on the fetus, such as catheter procedures, drainage of cystic adenomas, myelomeningeal seal repair, or fetoscopic procedures such as tracheal balloon or ligations, or urological procedures, and some selective terminations. And these are generally done with either regional neuraxial anesthesia techniques or general anesthesia. The ex-uteral intrapartum treatment exit procedure is generally performed utilizing general anesthesia for the mother. It involves manipulation of the fetus before total delivery from the placental circulation. It is a multidisciplinary team approach, most often done for chaos, which is a congenital high airway obstructive syndrome and it requires the maintenance of the uteroplacental circulation during the transition periods, very similar to cardiopulmonary bypass. And there are several listed reasons that these procedures are done. Intrauterine surgery in general, these are common concerns for all fetal procedures. You have 2 patients, the fetus and the mother, and you have to maintain and monitor both of them. You must consider the physiological changes of pregnancy, where the placenta is actually located. Fetal mobility may need selective neuromuscular blockade of the fetus in the case of the less invasive techniques. There may be a need for intraoperative and postoperative tocolysis, generally with terbutaline. One wants to assure adequate maternal oxygenation and perfusion, maintaining fetal normothermia, and for the open procedures, perhaps direct fetal monitoring. Normal carbia is preferred, and these women will need to be undergo surveillance for preterm labor, bleeding, and infection. Also, there is a concern that preterm neonates do mount stress responses to noxious stimuli, and this will not be blocked by maternal regional anesthesia, and thus some passage of intravenous sedations may be beneficial, but better passage of inhalation agents may occur to these fetuses. All types of muscle relaxants have been used by the fetus and do not pass to the mother because of the large size of the muscle relaxant molecules. These babies are at risk and have a high risk of neonatal mortality, even so with these operations, and may, in many cases, have some sort of intraoperative injury, so it elicits a urgent delivery. The exit procedure we've touched on before. Listed are some of the things that may aid with with the process. These include agents for intrauterine relaxation, such as the inhalation agents, intravenous nitroglycerin, preoperative nifedipine, and terbutaline or magnesium. There is a need for a specialized team for fetal airway modalities, and this generally is a pediatric ENT, ear, nose, and throat team.